Good morning. It's May 7th, and welcome to A Seat at the Table. I'm Lisa Courier, and today we have with us Valerie Sanz. Valerie is a social worker and actually going after her PhD right now. She's been a long-time advocate in the community and working in mental health for, I'll let her tell you about that. So, Valerie, welcome to the show.
Thank you. Thank you for inviting me.
Oh, I'm so happy for you to be here. Valerie and I met about 4 or 5 years ago at Shalom Free Clinic. Valerie was a therapist over there at Shalom, and I was a volunteer doing outreach. So we've been doing street outreach and outreach to those less fortunate, homed and unhomed, for a number of years. So tell me, Val, how did you get involved in wanting to do social work? And I know you're a very compassionate and empathetic person, so tell me more about that.
Well, I graduated from Chico State Social Work Department in 2007, and I have been working with the marginalized population since then in the community. And I went to work over in Napa following the earthquake in 2014 and did some crisis triage work in the street following the earthquake. And I liked their model, so I came back to Chico and started working with you to go into the street and implement the triage program that I learned in Napa.
So when you learn that, I mean, that's pretty valuable information because Napa has full funding. Didn't they get a grant from somewhere? Was it from the state, or where is it from?
It was a grant that came down through MHSA and was provided to the county, Napa County, and Napa County collaborated with 2 nonprofit programs in Napa, and they used the money to develop the crisis triage program.
Right. So together, Val and I, the nice part about it is that Val has the experience that I don't have, and I also have some street more experience than Val has. We make a really, really good team because, some people don't necessarily always make an impact or can communicate with different folks. Isn't that right?
Yeah, well, the thing that makes the relationship that we have working in the street so workable is that I have the clinical expertise and you have the boots on the ground expertise. You're very familiar with the population. You are able to go into areas that are unapproachable by other people. And so between my clinical skills and your expertise with the population, I think that we're able to reach a larger number of people that are homeless on the street.
Well, and a good thing, too. I mean, do you remember the one time that we went out to the guy's house and he didn't want you there, but you were able to talk to the police and get him the help that he needed, and I was able to kind of de-escalate him a little bit just by talking with him. So in that sense, her expertise in that is also the ability to make a decision on if the person needs to get extra help or not, right?
Well, and that was the model that we used in Napa as we went out into the street and did crisis triage. It was a prevention intervention model where we reached them before they went into the jail and were able to assess clinically and determine if it was necessary for them to go to the hospital, or if they needed to be 5150, or if there was a medical issue where they needed to have higher level of care. So we did the assessing and were able to work with the police and the hospitals and the PUF in Napa County and determine which was the best direction for them to get assistance.
The other thing, too, that is really on a positive note, this is what Val and I have talked about for a long time, is the 10 teams of 2. What's necessary is the clinical aspect along with the advocate who goes out on the boots on the ground and is out there. I think that rather than, we've been on many, many calls, and Val and I started working with, I started with Safe Space from day one, 5 or 6 years ago, however long it's been. And when Val and I met, Val and I started working on Safe Space. The first year of Safe Space, there was numerous calls to the police. And those were mental health crises that didn't need police intervention. But the volunteers were a little bit scared of people's escalations, if you will. And they weren't even serious escalations. I would say 90% of them were just people scared coming in, people needing just someone to talk to, a lot of hurt females who were hurt by somebody out on the street and were scared and dropping in, and they really needed some extra help. So the year that Val and I started being the main point of contact every single night at Safe Space, there were no police calls. So we went from about 10 or 15 to 0. That was about 3 years ago, right?
Correct.
So the nice part about that is that the de-escalation training that we both had, I went through the police model, and I'm post and certified with the Memphis model and mental health counseling, along with all of Val's education and training on those things. We find people who are just at their wits' end and don't know how to deal with it properly. So doing wraparound services with these folks is crisis prevention, and then getting to know the folks. Talk about baseline functioning and knowing what that is, Val.
Well, when you approach somebody who is in crisis and they are traumatized, they're in crisis, maybe they have lost or not been on their medications, and you want to make sure that they achieve their baseline functioning, you direct them, refer them, provide a warm handoff to the appropriate place to get the intervention. The thing that CCAT has been able to do is, following the intervention, Lisa and I have been able to reconnect maybe after they've been discharged or they've been stabilized back to baseline functioning, and pick them up and make sure that they either go to court, get their medications, maybe get their Social Security, food stamps reinstated, and provide some intervention so that they can continue on their baseline functioning.
And what Val taught me, long ago is about the wraparound services. So it's really important for us to recheck with these folks. We still have relations with most every single person that we've touched so far, right, Val?
Correct.
And so we recheck on them and make sure that if they do come back into Safe Space or they do come back into a shelter, that we actually know what their baseline function is, because we pay attention to those things. So somebody might think of it as escalation, and some of those, that might be their baseline.
Correct. And it takes a long-time relationship to be able to determine baseline functioning. A lot of these folks don't have supportive care that have been following them as long as Lisa's been following many of them. And so she's an important component to understanding where these people are at baseline.
I think it's a team effort too, and I think that collaboration with other folks that are doing the same thing, is pretty fabulous. Let's talk about the system a little bit.
The system.
I know we both laugh about that.
The system. Well, I have been working at the psychiatric hospital facility in Butte County for the last year and a half, working in the system of mental health. And many of our clients that we work with in the street have come through the system, if you will, for mental health services.
So, and I'm just going to put it bluntly out here to you folks. The system, when we're talking about behavioral health services here in Butte County, are limited. And everybody wants to say that Butte County has a handle on our mental health. We don't. We have a $67 million budget in Butte County behavioral health, but they only service the severely mentally ill. And a lot of times when some organization or it gets too full, then there's another person who's getting worse out there than the person who they've just treated for 3 days. That person gets released. And a lot of times we can't even get somebody into services. Over at Enloe, you have to have insurance in order to do it, and they have, I think, 15 or 20 beds, and normally there's only 5 in it because that's for full pay or insurance folks. I think there's a problem there, right? Over here, we have so many people suffering from mental illness, and severity is the reason on if you get in or not. Isn't that right?
Well, the PUP does select the acute that is assessed clinically to determine if they meet criteria for services. The concern that I have over at the PUF is that they have employees that are not trained clinically, that they don't have a clinical background, that they're making clinical assessments for the acute mentally ill, and they do not have the qualifications to make those kinds of assessments, yet they're in those roles and they're labeled, identified, classified social workers with a caseload and making sure that these clients are receiving the services that they should be getting in behavioral health, in acute mental health facilities.
And we need more funding actually for more beds, because the problem is that even if we had 10, 12, 10 teams of 2, like I talk about, an advocate and a social worker, and also the transporters that can transport people to court or to get their necessities met, to go get their prescriptions or that kind of thing. And we need a locker place downtown, or maybe not downtown, but somewhere for people who are homeless to keep their medications, because when their items are stolen or they're arrested and taken by the police or whatever reason, and they don't have their medications, that changes the baseline, doesn't it?
Well, then that will precipitate a decompensation for many of these folks who have long-term mental health issues, and their medications keep them stabilized and at baseline. And then when they're living on the street and they don't have anywhere to keep their medications, they're stolen, they're lost, they're not stored properly, and then the patient begins to decompensate, and then the revolving door begins, and they are either picked up by the police, taken to the jail, sent to the PUF for restoration, back to the jail where they sit and wait for their hearing. And what we'd like to do is to be able to reduce that recidivism, reduce that bottlenecking happening at the jail, where now you've got mentally ill people sitting in a jail waiting for their court hearings while the PUF is at capacity and unable to transfer for restoration or determine baseline functioning on medication.
Well, and that's a really good point, because the definition. So here's what we need to change, people. Listen very closely. When you're over at jail and they find you incompetent to stand trial, then they send you over to either Napa or Atascadero or to the PUF to regain your competency. And if you're found unable to regain competency, the definition of that does not match the gravely disabled from the behavioral health. So behavioral health classifies it as gravely disabled if you're a threat to yourself or to others, you can't find a place to go eat, or you can't find a place to shower, but you're still found by the court incompetent. So there are a lot of people out on the street that are totally incompetent, can't keep their stuff together, and that's due to their mental illness or their addiction issues, but they're not gravely disabled in order to get the help that they need. So in order to get a conservatorship, an LPS conservatorship, and get the extra help that you need, or get into a different placement for someone with mental illness, the law must change. We must take a deep dive and look at what happens when you're found incompetent versus being gravely disabled. This is really a problem.
It seems to be a subjective term. when one is deemed gravely disabled, it is defined by inability to provide food, shelter, clothing for yourself, an inability to manage or maintain one's own independence. And so consequently, then they will hold you, whether it be a 5150, a 5250, or a 5270, they can continue to hold you if they deem you incompetent or gravely disabled. Unfortunately, the people who are making these clinical decisions are not all clinicians. This is my concern, is that they have people working over there who are not clinically trained, who are not clinically educated, and do not have the clinical skills to make these types of assessments.
Whew, that's a lot to take in, isn't it? And, I thank you, Val, very much for being here with me. Is there anything that you think that we can do better without money or is there anything that you think we can do better?
Well, being trained in the crisis triage model that I used in Napa, that has been very effective in Napa. It's a prevention and intervention project that has worked well for reducing the recidivism, reducing the bottlenecking at the police, reducing the jails, the capacity, and being able to provide wraparound services and warm handoff, appropriately placing these people where they can get the services they need, while picking them up at the intervention and being able to provide them the linkage to the services to continue getting the resources necessary and getting them to a place of stability. Now, housing is always a problem wherever you are. It was a problem in Napa after the earthquake. It's a problem now with the campfires. It's going to be an ongoing problem for a long time. But I think that there are other people in this community who are working diligently, tirelessly, and sacrificing much of their time and energy to ensure that housing is a priority. And not just for the campfire victims, but for the displaced in Chico now because of the price wars, the gouging, the way that the community has been taken advantage of by evicting people out of their homes so that they can raise the rents. It's just a travesty that's not just about the campfire victims or the evacuees. It's about the community of Chico and how we have taken advantage and exploited the campfire to pave the way for profit. And I think that we need to be more mindful about how we're going to house those that are already displaced, and now those who are displaced and the working poor who have been outed economically of their own price range.
Well, and that's a sad state of affairs because you're affected by that, and I know at least I can tell you 20 different names that are also affected by that, and that's an extreme tragedy that people are moving out of town so that they can live, and moving back with family members in order to help the family members, but also maintain their head above water. It's a difficult situation all the way around.
And so I think that if we're going to restore this community to the Chico that it used to be and the Shangri-La that I moved here to raise my family in, we need to be mindful of do unto others, to remember the golden rule, to reach out and lend a helping hand to your neighbor. And I think that just because the city council says that they've got a cap on rentals, that they cannot exploit the campfire victims or evacuees, that we really need to be mindful that it's happening and people are being displaced, and these are not just the victims of the campfire. They're Chico people who have lived here for generations who now can no longer afford to live here because of the price gouging.
Yeah, and that's true. I mean, we're finding so many people that are getting upset over nothing, and causing wars amongst each other too, as well. I mean, I saw on Facebook the other day that some lady was complaining because she was walking her dog, and the people picked up the dog poo and put it in her trash can. We're complaining about so many things that nothing is being happy. There's very few things that are being happy. We want to nitpick about every darn thing that's happening, and we need to get back to the basics. We need to sit down at the family table. We need to get back to communicating. We need to get back to laughter and having fun. And how can you possibly do that when you're financially just going under in a community that you love and want to stay in?
Yeah, that's the big question right now, Chico.
Right. Val, I appreciate you, and I have loved working with you all of this time. We will be life friends, and I thank you for all the valuable input that you've given to me, the help that you've given to me, and all the teachings of stuff that I needed to learn in order to be able to be effective with folks. I mean, we have a ton of clients right now, and it's overwhelming. And we made a conscious choice not to go out with the police in order to do the work that crisis care advocacy and triage does, because I can walk almost anywhere. There's a couple places in town that I will not go, but I can walk almost anywhere and know one or two. And if I know one or two, I am safely able to approach. And that's the beautiful thing about us doing this work, is that we build the relationships. And quite frankly, we're not built. The transformation of the community is not built by memos or by emails. It's built by one relationship, one conversation at a time, over time.
Correct. And I just want to thank you for that, Lisa. Appreciate you as well, because we did build this crisis care advocacy and triage team, and it's growing, and it's fruitful, and it has good outcomes. And I'm grateful that we took this project from Napa and this model and utilized it and grew it. And we've been able to be effective and help people in this community. I'm grateful for your efforts.
Thank you. So that's going to be it for today. This is A Seat at the Table, Volume 2, on May 7th, 2019. We appreciate you. And next week we're going to have a young lady who was an IV drug user, 75 days sober now, about to get her child back, and about to be housed. It's a pretty spectacular story, a really positive solution that CCAT has used for wraparound services for her, all during her mental health appointments through her court, and day to day we talk, and I'm really, really proud of her. So we'll see you then.